Good afternoon, everyone. Welcome. Thanks for being here with us for our webinar today to learn more about our partnership with OncoHealth. If you have questions during the presentation, as a reminder, please feel free to put them in the Q&A chat at the top of the bar. If we have time at the end, we will try and answer any questions, but if not, we will make sure your sales representative reaches back out to you. I am your host, Kristen Wuckelchuk, and I am a marketing manager on the pharmacy team. And today I am excited to be joined by our speakers, Dr. Andrew Norden, who is the Chief Medical Officer at OncoHealth, and Morgan Prokopenko, a PharmD and one of the clinical account consultant pharmacists on our team. Before we dive into the presentation, I want to take a moment to reiterate our mission to help people in our communities live healthier and more secure lives through access to high quality, affordable healthcare. This mission really guides everything we do in our approach to pharmacy management. So by the end of today's presentation, you are going to know more about oncology trends, as well as the power of our partnership with OncoHealth. So without further ado, I am now going to pass it off to Morgan to get into the oncology market trends.
Thank you, Kristen. And again, thank you to everybody who has joined the call today for our second webinar. So first, getting into some of the oncology trends that we should be preparing for as we close out 2025 and heading into 2026. So cancer is the second leading cause of death in the US, and incidence of cancer has slowly increased year over year, in part due to our aging population and also due to better technology to make that detection a little bit stronger. So 2025 is expected to have over 2 million new cancer diagnoses. This is the second year in a row. So again, we're going to have a big number of cancer diagnosis, and these members are typically 4 to 5 times more costly than those without cancer. Oncology is a very rapidly growing market. We see multiple drugs gaining approval year over year. And when we talk about oncology drugs, we don't specifically just focus on, pharmacy benefit drug. We have to really look at both the medical and the pharmacy benefit. These drugs that are getting approved are becoming more targeted. We see new cellular and gene therapies coming to market specifically for oncology indications, and even existing therapies gaining expanded indications. I like to use the example of Keytruda that was approved for one indication about a decade ago and now can be used to treat over 18 different cancers. So if we have expanded indications, it's going to expand out that population that qualifies for the drug and increase cost there. There's also a very robust pipeline in the oncology space. A lot of research and development is placed in this category. So again, we have multiple new drugs coming to market, which offer innovative treatments for our members and for our population, which is great. They target cancers that may not have any therapies or offer additional options, but again, are coming to market at a very high cost. In 2024, there were 16 new oncology approvals, but with an average cost of $450,000 per treatment. So, balancing access to that treatment with the cost of therapy. With these high cost medications, oncology continues to be a top trend driver for a lot of our employer groups. We have seen double-digit trends within the oncology space. So we do have to be very mindful and continue to track these new drugs that are coming to market to make sure we have the correct policies in place and strategies to help our employer groups manage that spend. When we focus more specifically on the pipeline, as I mentioned, a lot of these newer drugs are targeting those more rare cancers, those that have either no treatment options or there's a gap in care there. We already have seen 8 approvals in the first half of 2025 and anticipated another 9 potential new drug approvals in the oncology space in the first 2 months of the second half of the year. We've already seen 3 drugs gain approval. So this year is going to be another record year for oncology drug approvals. On the flip side, when we look at pipeline, we also have to think about those drugs that are already available on the market and when they will lose their exclusivity or come off patent. So have a generic or biosimilar option. We do have several both oral, so drugs that would be covered on the pharmacy benefit, and medical drugs that would be, or IV drugs that would be covered on the medical benefit that are anticipated to lose their patent over the next 5 years. So this year we've already seen Tasigna lose that exclusivity and come to market at a much lower cost than the brand product. And over the next few years, we'll see drugs that target breast cancer, lung cancer, multiple myeloma, and then you'll see the 2 heavy hitters on the medical side, that Keytruda and Opdivo. Those are anticipated to have biosimilar competition by 2028. So we are tracking both new drugs, but also those drugs that lose patent exclusivity to help to offer financial relief when it's available. So when we move into talking about leveraging the power of partnership, we do just want to touch on our refreshed pharmacy value story. So we did launch this earlier in the year about having quality prescription coverage and what we're doing to bring that to our clients. So we bring a holistic approach and a lot more value. So we have an extensive range of cost containment solutions available to help make these medications more affordable and promote proper utilization to help improve the health of our community. Our model is built for your benefit. So we have, the local and national expertise that we're able to drive to the lowest net cost of these medications without sacrificing any clinical for our members. And we really try to make every service experience seamless. Having that one card, one place for the member to call in. And then last but not least, leveraging the power of partnerships. So what we're really here to talk about today. So driving the progress through these partnerships, we have collaborated with the providers in our communities, collaborated with drug manufacturers and bringing first-in-class programs. But today, again, we have Dr. Norden to talk about one of these specialized vendors that we've partnered with, OncoHealth, to help manage the trend in the oncology space. As you can see, we have delivered significant value through this partnership with almost $18 per member per year savings through our relationship. So with that, I will pass it over to Dr. Norden.
Morgan, thanks so much. And it is a pleasure to be here with you all today. I'm going to start by telling you a bit about OncoHealth, where I serve as Chief Medical Officer. As you can see at the top, our mission is oriented around delivering oncology-focused solutions to reduce the physical, mental, and financial tolls of cancer for all of the various stakeholders in the market. And we've been in this business for more than a dozen years now. We work with nearly 20 health plans. In fact, it may be 20 by the end of this webinar. We support more than 12 million members, and we've consistently had really high provider satisfaction, which is a key area of focus for us. It says 90% here, but usually it's meaningfully better than that even. As Morgan said, we deliver lots of financial impact savings to the health plans and employers that we work with. And we've maintained a very high consumer or patient-facing NPS score, which is extremely important to us as well. At the core of our mission is our belief that having clinical experts in-house and driving much of this work is really important. And that's why I'm happy to say I lead a team of really expert physicians, nurses, pharmacists, mental health therapists, and dietitians, all with deep oncology experience, and many still practicing oncology in some way in addition to their work with us. Morgan certainly pointed to this as well, which is that oncology is a very challenging environment for all of the individuals and organizations that are obliged to pay for cancer care. The number of drugs coming to market has been consistently high, and we're expecting to see 100 or more new drugs in the next 5 years. That number is oriented around new drugs, but if you count new indications for existing drugs, then the number goes up by multiples, because increasingly we're learning that the drugs that come to market have multiple effective indications. As you could imagine, practicing oncology is challenging because of the explosion of new drugs, new biomarkers, clinical trials that you might want to enroll a patient on, and so forth. It can be really, really overwhelming. Most oncologists say so, that they struggle to keep up. And the truth is that an oncologist could spend all of the time in the day reading articles that are being published that are relevant to his or her practice, and still struggle to know everything that they need to know to provide the best possible care. And then really problematically is that the median annual price of a newly launched cancer drug is astronomical at this point in time. In 2023, it was $300,000. It's well on its way to $400,000 now, and certainly within the next 5 years, it's likely to hit $500,000 plus, which just really challenges the various payers. So OncoHealth was built with the goal of optimizing the quality and cost of cancer care and ensuring that every patient has access to the best possible cost-effective outcome. We were founded by a medical oncologist and take our mission to patients and physicians very seriously. At the core of our service offering is an electronic prior authorization portal that's installed in the cloud, and therefore available to oncology practices to submit requests. They can request a combination of medical and pharmacy drugs, and we review those together in a regimen-based format. And I would say this is a unique characteristic of our portal. Traditionally, one in an oncology office, one is obliged to submit medical and pharmacy drugs separately, one typically to the health plan or the health plan's vendor, and one to the PBM or the PBM's vendor. Our platform is called OneUM because it enables one to submit all of the drugs for a given patient, including supportive care drugs, and in fact, radiation oncology requests and genetic and molecular testing requests related to cancer, all in one place. Doing this all together allows us to ensure that the regimen being authorized is the optimal approach for the patient, most effective and safe, and it lets us control inappropriate use. And as you can imagine, given the pace of drug development, the aggressiveness of new drug marketing, inappropriate use and overuse are real in oncology. It's also the case that oncologists operate under pretty strong perverse financial incentives that influence their behavior. Not so much consciously, I don't think, but by virtue of psychological realities. We also enable submission of supportive care therapies like anti-nausea drugs and white and red blood cell growth factors and targeted therapies, the whole gamut of anti-cancer therapies can be submitted in the portal. And then on the back end, invisible to the patient and physician, the authorization information gets transmitted to the health plan so that claims will be paid on the medical benefit, and to the PBM so that the relevant claims will be paid on the pharmacy benefit side. Some of the key mechanisms we use to bend the cost curve are listed here. Of course, I alluded already to the notion of reducing use of non-evidence-based therapies, and that is important. We also, as I discussed, review the cocktail of drugs that an individual patient may get across benefits, and we do that together, which allows us to be sure that the drugs in question are being used in the best and most evidence-supported ways. We have deep at our core a desire to collaborate with requesting oncologists rather than to issue denials. We review every request carefully and read the medical record provided in its entirety. And then when we collaborate with the requesting physician, we work hard to offer tailored alternatives when we're not able to issue an immediate approval. All of our clinicians are oncology experts, board certified, and those are the individuals who get on the phone with requesting physicians so that requesting physicians can feel confident that they're engaging with a true peer. Certainly, we ingest and customize our operation around each health plan's individual drug and step therapy preferences so that we can support those. And we also spend a lot of time advising our payer and employer clients about optimal strategies that they may wish to put in place that are cost effective and ensure that patients get the right combination of high quality, high effectiveness, and minimally toxic therapies. And then we also support some unique programs like site of care steerage for commercial members, the notion being that there can be really material cost savings associated with the administration of selected drugs in certain clinical circumstances in lower cost settings like a physician office infusion unit rather than a hospital-based infusion unit, or the patient's home, where many patients increasingly prefer to get a whole variety of therapies, including anti-cancer therapy. And then we also offer a vial optimization program that in a really smooth and largely automated way helps physician offices make appropriate drug dose rounding decisions so that they minimize the waste that the overall system is obliged to pay for. Here we refer to our white glove approach, and this is really true. And I think if you talk to the oncology offices that we interact with every day across New York and multiple other geographies around the country, I think you'll find that they'll tell you that our approach is in fact highly interactive, collaborative, white glove. This is why we have a very high initial approval rate of around 90%. There is decision support at the point of case entry that helps practices ensure that they're submitting approvable regimens in the first place. When an initial request is not approvable, we work very carefully and collaboratively with the practice to encourage a change in that request to something that is approvable. Or in some cases, we may have a conversation that results in the oncologist deciding that, in fact, the patient maybe isn't likely to benefit from any therapy, and or maybe not likely to benefit from any therapy right now, and they might withdraw the request. The way we do these conversations, as I said earlier, is we have board certified, often practicing oncologists on the phone with oncologists in your community, and we work with them to review the data, guidelines, and evidence, and help get to a good, optimal yes. We maintain a low denial rate because of the approaches that we use to collaborate and get to yes. And this is valuable because it means that appeals volume is very low. And it means that we are less likely than many in the prior authorization industry to create angry physicians, nurses, and patients. So I thought it would be worthwhile to walk through a real example to give you a sense of what happens in practice and how we are driving clinical efficacy and cost containment at the same time. This slide has a lot of clinical jargon on it that it may be familiar to some, but not all of you. And so I'm going to try to focus on the high level points. But this is a real case of a woman in her 50s who has colon cancer metastatic to the liver, and she was treated with we reviewed and authorized a standard treatment regimen for metastatic colon cancer called FOLFOX and Avastin. It's a 4-drug combination. And it's well known that patients being treated with FOLFOX and Avastin have a significant risk of febrile neutropenia. Febrile neutropenia is a condition where a patient develops an infection because of low white blood cell counts due to chemotherapy. And therefore, routinely, it's recommended that patients who are on FOLFOX and Avastin for colon cancer be treated with a white blood cell growth factor that stimulates production of white blood cells so that the counts never go down or don't go down for as long. And in this particular case, the patient got a flavor of a white blood cell growth factor called Udenyca, which is a biosimilar for Neulasta, pegfilgrastim. And things were going well. The patient was benefiting from the chemotherapy and having no problem with the Udenyca. And then we received a reauthorization request because the 6-month authorization timeline was about to lapse. What we learned at that time was that one of the drugs that is part of the FOLFOX backbone, FOLFOX is 3 drugs, and Avastin 1 more. One of the drugs called oxaliplatin, which is the ox in FOLFOX, had been removed, was not going to be continued because the patient was having some side effects from it. That's something that happens sometimes. You have to eliminate one of the drugs that may be causing a side effect. And so the request was for continuation of the other components of FOLFOX and Avastin with Udenyca, the white blood cell growth factor support. And when we reviewed this clinically, our pharmacists quickly observed that the truth is that the reason white blood cells go down when patients get FOLFOX and Avastin is because of the oxaliplatin. And so in this case, the oxaliplatin was being omitted, and therefore the risk of white blood cells going low and the patient developing febrile neutropenia and an infection were very low, and therefore Udenyca is no longer appropriate. And so that's problematic because Udenyca has a significant cost that can add up to, it's in the range of $3,000 a dose. It can add up to tens or even hundreds of thousands of dollars over a patient's course of therapy. And not to mention that Udenyca itself has side effects that can be problematic over time. So we had a collegial conversation with the physician who had issued this request. He was really appreciative that we had recognized that his office was inadvertently continuing Udenyca when it was no longer needed. And he thanked us for the call and removed that from the request. And we were able to approve the other drugs that the patient did need in an ongoing way. And given the duration of therapy, we saved something in the range of $120,000. So we try to do it this way as often as possible, which is to say we're trying to optimize the quality of care and the cost, and do it in a way that is beneficial to patients and their physicians, and reduce the level of financial impact on the system overall. So just to wrap up, OncoHealth is an expert oncology utilization management company, been in the market for more than a dozen years. We work really hard to do this better than many in the industry in a more collaborative and more scholarly, evidence-based way. And we're having quite a lot of impact in your market, and we're proud to work with many of you. And I thank you for your attention, and we'll turn it back to Kristen.
Thank you so much. I do have a couple questions that have come through that I'm going to direct over to you, Dr. Norden.
Okay.
The first being, could you speak to how you collaborate with oncologists in the market?
Yes, absolutely. There are two key things I'd highlight here. One is when we start working in a new market, we initially go out and meet with all the key provider practices that we're going to be working with. One, we want them to know who we are and what we do and how we work. And two, we want to establish contacts in that practice and provide our contact information so that they know if they have a challenge in working with us, that there's someone they can contact and get a quick resolution. That's how we do it sort of at the practice level. And then on a per case level, we actually do a lot of communication using all the standard mechanisms. We communicate within the electronic portal directly with practices. We certainly send and receive faxes, but nobody likes those, even though they're used quite often in 2025. And then our physicians and pharmacists have conversations with the clinicians in the practices themselves around individual cases that we work through together.
Thank you. Not the faxes.
Nobody likes faxes, but
yeah.
they just continue to go.
Yeah. And then the second question, you talked a little bit to the regimen-based review. Can you explain a little more about what that means and why it's important?
Yeah, that's a good question. And that this is unique to oncology. Oncology is different from common diseases. You know, in a patient with high cholesterol, one prescribes a medication. In patients with diabetes, one prescribes a medication. But in oncology, typically one prescribes a cocktail. And often that cocktail represents a combination of anti-cancer drugs, very often and increasingly so, drugs that may be a mix of injectable and oral drugs across the two primary drug type benefits, medical and pharmacy benefits. Sorry, I just lost my train of thought, but I'll come back. I'll come back to it. So it's typical that we receive a request for a bundle of drugs, and we've set up our system that way. What's important about oncology is that this is the combination of drugs is the mechanism by which drugs are developed and studied. So if you read clinical trials of cancer therapies, you'll see that cocktails are being studied, and therefore, if you read oncology literature, oncology evidence-based guidelines like those from the National Comprehensive Cancer Network, NCCN, you'll see that an oncology drug might well be appropriate for a given patient, but according to the evidence, only when given in combination with another one or two drugs, specific ones. And so the point is, in oncology, if you look at individual drugs, you can't know if they're being used appropriately. You need to know the characteristics of the patient, and you need to know the entire group of anti-cancer drugs that are being given to our patient. And so that's the mechanism by which we review cases to make sure that the request we're getting is medically necessary and represents the optimal efficacy and cost parameters for a given patient. Typically, in the prior authorization space, an oncologist is obliged to submit a request for the medical benefit drug to one party and the pharmacy benefit drug or drugs to another party. And we think that's problematic and confusing, and more often leads to errors and uncertainty about whether drugs are being used appropriately. So we built the 1UM platform to recognize that oncology is based on regimens as a scientific field, and therefore that's the mechanism by which we permit oncology practices to submit and have their requests authorized.
Thank you. That was very insightful. All right, there's no other questions that have come in. So with that, we are going to wrap up. I'm going to send out a quick poll. It's just a quick 5-star rating about how you enjoyed today's content. It'd be greatly appreciated if you could rate that for us just to get some feedback. And thank you to Dr. Norden and Morgan for joining us today. We really appreciate your time and expertise. And thank you to everyone who attended. The recording will be coming out shortly. So until next time, take care. Thank you.
Thank you.